we bring emotion to work with us. We can't leave emotion at the front door. I think from an HF perspective, if you're angry, you're about 30 times more likely to make a mistake.
Hello and welcome. I'm Ceylan Simsek for today's podcast. I'll be joined by host of the In Dentistry series, Dr. Yvonne Shaw. Great to be with you, Yvonne.
Thank you, Ceylan. It's great to be doing this podcast with you.
This is a bit of a different podcast because both our medical protection and dental protection listeners can catch it on both channels. The reason we can do this is because we're speaking with a unique but hopefully familiar guest for our members. Yvonne, would you like to introduce our guest and podcast for today?
Yeah, certainly happy to, Ceylan. So, as our listeners know, we've been having a lot of conversations about diagnostic error and delays. And today we're going to really hone into what we can all do to improve diagnostic safety. Now, today's guest is none other than Professor Peter Brennan, who's been a consultant oral and maxillofacial surgeon based at Portsmouth Hospital's NH Trust since 2002. Now, Peter traverses both of our medical and dental worlds with clinical interests in head and neck malignancy, reconstructive free flap surgery, and neck lumps. He's also a research supervisor and examiner for higher research degrees and has published over 700 papers to date, and 80 of those are on human factors and patient safety. Peter's research has also been awarded both national and international research prizes, and he's lectured extensively in the UK and abroad.
So, Peter, welcome. And we'd just like to start off with a broad question of what are human factors in healthcare?
Well, thank you both for the invitation. And yeah, that's a good question, isn't it? Really. And I think for me, the clues really in the title, human factors. So as humans, it's about optimizing our performance through an understanding of how we work together, our behavior, our thinking processes, our interactions, and interactions not only with ourselves but also the environment and equipment. And that's a separate area of ergonomics.
So, Peter, was it a specific incident that sparked your interest in human factors and the impact on the delivery of healthcare?
Yes, I think it was one. I think probably about 13 or so years ago now, I had an airline pilot who came into theatre, very interested in surgery, and basically just opened my eyes to something called crew resource management (CRM), which is how team members interact and work together, the communication, some of the hierarchy things, and just things that I hadn't really thought about. And we were operating for 4 or 5 hours without taking a break. That's what I used to do. And he was, well, hang on, have you thought about taking a break? You're surely getting a bit tired. So sure enough, yes, we stopped. We took a break. I was a bit skeptical, if I'm honest. We walked away for 10, 15 minutes, came back, and the morale and the performance of the team was so much enhanced. We actually caught that time up, and I guess the rest is history, really.
It's really interesting. Thank you.
And how do human factors relate to diagnostic error, Peter?
Well, diagnosis, sort of massive, great topic, isn't it? Really, and I guess diagnosis can be a very simple process. So a spot diagnosis of a lump or a skin lesion or a decayed tooth, for example, or it can be very, very complex. But even simple decision making can be influenced by all sorts of things. Distraction. Someone coming into a room, for example, when you're reading a CT scan or you're interpreting results. Multitasking, we do that all the time, don't we? We're typing an email whilst we're looking at something else. Confirmation bias, I think we'll talk about that a little bit later on, but looking for clues that actually confirm what we're thinking rather than looking at the broader picture. And sometimes actually finding something that we think is important, and then we hone into onto that, and maybe forget that there may be other factors or processes involved as well. So a simple question, but a complex answer, I guess. And then finally, how we're feeling emotionally, whether we're tired, whether we're hungry, whether we're working under pressure, whether we've had an extra patient added on to our busy clinic or what have you, and the pressure's on. All of those can affect diagnosis.
Absolutely. And you've mentioned various things such as distraction, unconscious bias, being tired. So how do factors contribute when an error is made? How does that happen?
Yeah, well, most error, in fact, when you dissect it out, and we've looked at errors across healthcare and published a lot on that as well. Most error is multifactorial, so there's not one single thing that causes the error. Yes, you as the practicing clinician may be responsible for example, taking out the wrong tooth or missing something on diagnosis. But actually, leading up to that, there's a whole list of other things that actually contribute to that error. So most error starts in an organization, so-called latent failure, something that you might not have thought about. So, for example, we mentioned that it's running late, it's having an extra patient added onto your operating list, it's doing a ward round with extra patients that are added on which you've missed, for example. It's all those organizational type issues. And then you've got the so-called preconditions to unsafe acts. And they're some of the things I mentioned just a while ago about the tiredness, fatigue, hunger, thirst, team dynamics, hierarchy, and so forth. And then finally, things like unsafe supervision. And that would include not only unsafe with supervising more junior members of the team, but things like failure to engage with a checklist. So all of us use checklists, but do we engage with them as if our own life or limb or tooth depends on it? And the answer is probably not. A lot of people that I've seen, and in fact me as well, until I started understanding human factors, it was a tick box exercise. It was something that we had to do before we got to the operation. If you change culture and you engage with that checklist as if your own life or limb or a member of your family's actually depends on it, then it's much safer. And then finally, the unsafe act itself. So all of those things coming together, then the unsafe act itself happens, and that's what leads to an error.
Thanks, Peter. I think you've mentioned a lot of kind of like individual factors, but also environmental factors. And I'm sure you'll agree in the last few years, our medical and dental colleagues have been probably facing an unprecedented number of challenges that are impacting delivery of healthcare, such as working during the COVID pandemic, managing the backlogs that pandemic's now generated, patient dissatisfaction. We're certainly seeing a lot more complaints coming through from members. And then coupled with that, we've got new ways of working. So we've got remote working. And then more recently, we've got strike action, which is obviously going to impact upon resource. So a massive number of pressures on our colleagues over quite a prolonged period of time now. So I suppose from a human factors perspective, what are your thoughts on the current environment and the risks? And I suppose thinking, further down the line, what steps can clinicians take to try and offset some of that risk when they're perhaps coming under more and more pressure to work longer hours and cover these absent roles?
Yeah. Well, it's been an unprecedented 3 or 4 years, hasn't it? Really, and in the initial stages, I think loads of public support. There was all the clapping and things, and of course now coming out of the pandemic, 7 million patients, I think, on waiting list for operations. The workforce has been through it, all the uncertainties of the virus, all the worries, all the pressures, and so forth. So we live in unprecedented times, and for me, I think human factors are even more important than ever, particularly with many of us having fatigue, and burnout again is another issue. So I think there's a difference. I think we should emphasize the difference between tiredness and fatigue. Many of us are feeling fatigued. Tiredness is a physiological state, so it's a little bit like hunger. If you're hungry, you have something to eat, and your hunger goes away. If you're thirsty, you have something to drink. Thirst goes away. If you sleep, then your tiredness goes away. So it's a physiological state. Fatigue is much more complicated. And yes, you can have an acute fatigue. So you run a marathon, for example, or you're up all night or a couple of nights and things. But over a period of days or weeks, fatigue is far more complicated. And that's where many healthcare staff are at the moment. And actually recognizing it in ourselves, recognizing some of those symptoms. So irritability, tiredness, can't be bothered to do the work, irritability with colleagues, anger, those sorts of things. And they're the cognitive and the kind of the emotional side of things. And then you've got other factors as well. So, particularly in surgery, not operating for long periods of time, and you're then suddenly expected to come in and do a complex operation. So in aviation, and I don't think we should ever compare aviation to healthcare, they're completely different. But in aviation, there's something called currency, which is you have to do a certain number of landings per month and what have you. In surgery or in medicine, we haven't done something for 6 or 9 months, and yet it's okay to pick up a knife and go straight for it straight away. So there's a potential lack of currency. Changes in circadian rhythms, with shift patterns and having to do a set of nights and then maybe a day or two off and then coming back into it. Lack of sleep, all of these things. So it's a really complex situation at the moment. And of course, government pressures from the public, pressures in the national press and on news about waiting lists and patients complaining, Yvonne, as you've already mentioned. So pressure's really on, and it's recognizing that and actually mitigating against the potential issues, which opens up a whole new area of threat and error management in itself. Perhaps something for another podcast.
Yeah.
And do hierarchies play a role in stopping someone from speaking up, either before, during, or after a diagnostic error is about to be made, especially that juniors might be struggling against speaking up against seniors, or seniors potentially not speaking up for fear of being seen as incompetent?
Yeah, very interesting question. I think first and foremost, there has to be a hierarchy. There has to be an overall leader of the team, a consultant, a senior nurse, a matron, whoever. There has to be that person that everyone looks to. If there isn't any hierarchy, it's a so-called laissez-faire. So no one quite knows what on earth's going on. But for me, I think there should be a very gentle hierarchy, such that any member of the team, and that can be both intra-professional, so colleagues in the same specialty, and inter-professional, so nurses, other healthcare staff, can actively challenge and without fear of retribution as well. So that's really, really important. And if you're an unapproachable consultant and you instill fear into your trainees, for example, they're going to feel uncomfortable, and they might not feel able to speak up and challenge if there's a patient safety related issue. So lowering gradients such that anyone can speak up is really important, and it actually extends much deeper than that. It's about the culture of the NHS, isn't it? It's about having that just culture. So if something goes wrong, if there is an error, it's not who is to blame. It's why did this happen, and what can we do? What measures can we put? What systems can we adopt to prevent it or to reduce it from happening in future?
I wonder is it just hierarchy, but I just wonder if there's maybe cultural and generational differences that also might impact an individual's willingness to speak up. And I suppose the question is, how can those differences be addressed, and what can we do on a personal level to try and change embedded behaviours?
Yeah. I think so, and I'm just amazed actually at the differences of people coming in to meet us with medical students, for example, coming into theatre. I always introduce myself as Peter Brennan. I don't say I'm professor or whatever, and they can call me whatever they feel comfortable with. And some medical students will instantly say, "Oh, thank you, Peter. Thanks very much," and that's absolutely fine. And some will respect and will say Professor Brennan. And I think both are respecting, but it's they give that added level of respect. I honestly don't mind as long as the individual or individuals just feel comfortable. So yes, there is certainly cultural differences, but as the leader of the team, what I think we need to be doing is to ensure that whoever it is in that operating theatre or that clinic or that interventional radiology suite or your dental practice or wherever it is just happy to speak up if they just feel something doesn't seem quite right. And it's almost like a gut feeling, isn't it, when something just doesn't appear to be right, and so you just say, "Hang on a sec, please, can we stop? I'm not quite happy about this," and it's without that fear of retribution.
Thank you.
And we often tend to go from task to task without actually giving any consideration to the emotional side of things,
Yeah.
which you mentioned. So, element tends to often be overlooked. What emotional support systems could individuals lean into Are there any such as human factors, champions at hospitals, or talking to colleagues? What would you suggest?
Yeah. Well, emotion is a big one, isn't it? And of course, we bring emotion to work with us. We can't leave emotion at the front door. I think from an HF perspective, if you're angry, you're about 30 times more likely to make a mistake. That's the first thing. So huge numbers. And also the effect of anger, for example, on team workers. So you're much more likely to shout out at others. And if you do that, 80% of colleagues that do that subsequently regret their actions. And that's something called limbic hijacking. So it's our primitive limbic system overtakes our higher brain functions, which evolutionarily is much more recent. It's I think it's 500 million years old is the limbic system compared to 100,000 for a higher function. So it's very quick to overtake and to hijack. So my advice is actually to stop first before shouting. But yeah, having colleagues around, chatting with colleagues, having a network around you, both at work and at home, with family, with friends. Certainly, in some trusts, there will be well-being lounges, for example. There'll be places where one can go, one can get advice. I think we're a long way behind other so-called high reliability organisations or HROs. And one that comes to mind is National Air Traffic Services. A hugely reliable organization. They have a team of human factors experts that are there looking out for the air traffic controllers, telling them when to stop, telling them to take a break, and so forth. Sadly, in healthcare, we haven't got that at the moment. So we're having to rely a lot on each other to looking out for each other, taking those regular breaks, and empowering the team. And I can't stress that enough either. Empowering your team when you get to say 3 hours or 3.5 hours, if it's safe to do so, taking that break and getting someone to call that time out and say, right, come on, let's just take a break. Because if you're stressed and you're anxious, and we mentioned that earlier, risk of error goes up, and of course fatigue and all the other things come into play. So I see human factors a little bit like a balloon, balloon filled up with water. You press on one side and another side expands. You can't take these things in isolation. They all kind of act interchangeably.
Thanks, Peter. We've talked, obviously, there's a number of factors that impact our approach towards decision making, and you did mention kind of confirmation bias, I think, earlier on. Certainly, coming from a clinical background, I'm very much aware of that risk that you're looking at an X-ray and you've already got a diagnosis in your mind, so it kind of almost gives you tunnel vision when you're looking at that X-ray.
Yeah.
I suspect we have similar across medicine, getting results back where we're actually looking to find evidence that supports a diagnosis rather than taking that objective view. So are there any ways that we can look at that might reduce that risk of that bias in the way that we're approaching our diagnosis?
Yeah, that's a good one. And I mean, having that open mind, stopping to think before actually making that final decision, just thinking, is there something else? Could this be something else? Having that open approach. Having team members around you, and I mentioned about empowerment earlier, but having team members looking out as well, because a lot of them have got huge amounts of skills. Dental nurses working with dental surgeons, huge amount of experience and expertise. And if you empower them and you say, please look out for me, please, I want your advice on this. Not only is it good for team working, it's fantastic for patient safety and reduces the likelihood of error. Time constraints, I think we mentioned and touched upon those. Making sure you take time off to rehydrate and things. So if you lose a kilogram in body weight through loss of water, perspiration in the summer, your analysis and decision making, how you think and process information, falls by about 20%. That happens really, really slowly, and you don't even know it's happened. So taking the regular breaks, stopping, eating and drinking, morale is good. Tunnel vision, certainly. I mean, you mentioned that, and there's lots of examples of tunnel vision, and one of them actually is the clock. So you're concentrating doing a complex task. Suddenly, 2 or 3 hours has gone past, and you don't realise that length of time has gone past because you're tunnel visioned on the task in hand. So again, it comes back to team working, doesn't it? And having others around you looking out and stopping or asking if they're not 100% sure or if there's an issue with safety. and much better to stop if you can, just to stop, to step back, to down tools, rather than to go ahead and then take out a wrong tooth, which has happened time and again. It's simple things. I mean, human factors for me is very, very complex. It's an immensely complex subject, but actually at the heart of it is common sense application.
And I think certainly seeing a lot more kind of drive towards use of artificial intelligence and how that might kind of be used alongside healthcare. And I suppose the question is artificial intelligence going to help perhaps address some of those human factor issues? Alternatively, is it going to introduce new risk factors that we need to consider? I don't know if you've got any thoughts on that.
I think artificial intelligence is coming. It's here already, isn't it? I think it's great for certain things, for binary type things. So yes and no. Making a diagnosis. I mean, it's being used in all sorts of areas, mammography, for example, and things with varying results. So I think at the moment, I think it's fantastic as an adjunct to kind of help us to confirm what we're thinking rather than acting on its own. But certainly I see the future very, very bright with AI and, patient safety issues melting away, one would hope. Yeah, it's exciting times. But I don't think, or at least I hope it's not going to replace the judgment that a clinician has in the experience.
Yeah, totally agree. Thank you, Peter.
That's quite interesting. And given that it's not looking like it will replace individual judgment anytime soon, just for our listeners, what can each individual currently do to reduce error, especially when working within a multidisciplinary team where it can be that each person has their own obligations, their own responsibilities? How do you manage to reduce error in that situation?
Yeah. So a lot of us work these days in MDTs, don't we? And, for me, that it's really important. Everyone is valued equally, irrespective of who you are. So the most senior consultant to a medical or dental student, I value everyone equally. And that's all about empowerment. And we mentioned that earlier. Giving people times and tasks to do things to show that value. So one person's doing one thing, someone's doing something else. And even if it's an online, say an online MDT, and a lot of those are going that way at the moment, aren't they? Setting time limits and things. So doing an MDT meeting for 4 hours, and I know colleagues that do that online, and you can see the boredom, the fatigue creeping in. They start multitasking, they start picking up their phones and texting and so forth. Taking a break of just 2 or 3 minutes every hour. In fact, we've published on that, and it's just obvious, isn't it? But it's something, sometimes we forget to do that. A short little break, standing up, stretch the legs, a swig of coffee, and carrying on again. That can make a huge, huge difference. Avoid multitasking. So if you're in an MDT and you're doing things, multitasking is a big no-no. People continue to multitask. We've had drug administration errors. Many years ago, I was involved in an investigation with a nurse doing a drug round at a different hospital who was actually texting and gave penicillin to a penicillin allergic patient. So we shouldn't be multitasking. But working together as a team, empowerment, valuing everyone else, and ensuring all those things we talked about earlier, that we take the breaks and things, and we look out for each other. I think that would be my advice.
There's lots of points in there that listeners can take away, which is actually quite helpful in terms of reducing error. What about optimizing performance to reduce error? Is there any steps that our listeners could take?
Yeah. So for me, it's very, very simple. When you get on an aeroplane and they say put your own mask on before helping others. So if you're at 30,000 feet and you have a sudden cabin depressurization, you have about 15 seconds before you're going to lose consciousness. So if you're trying to help someone else, you're going to die and they're going to die as well if you don't get the mask on. And that for me is all about optimizing ourselves, looking after ourselves, and then we go and look after our patients. So I would just ask listeners, do you go to work in the morning not having had breakfast, for example? Is that something you do? Now, that might be something that you've done for years, but if you do that, you're not optimized. You're effectively in a fasting state. You're burning fat. You're generating ketones. Your brain doesn't like that. And there's loads of published evidence that shows that people that don't eat breakfast don't perform as well as those who do. Missing lunch, for example, we're missing lunch because the clinic's overbooked. And so we just continue on working. You wouldn't drive for 6 or 7 hours non-stop, or at least I hope you wouldn't. You would stop every 3 or 4 hours, get out of the car, take a break. And yes, it seems okay to be able to do that in healthcare. But just eating and drinking regularly, thinking about our emotional status. If we're running late, perversely, the thing to do is actually to stop, recharge, walk away for a few minutes, and then you catch the time up, in fact, because your performance has then come back up again. So there's something called HALT: hungry, angry, late, or tired, if you're any of those things. And if it's safe to do so, stepping back, getting out of that situation, even just for a few minutes, it can make a massive, massive difference to performance.
Thank you so much, Peter. And that's been a really interesting conversation. Thank you so much for joining us today.
No, thank you so much for the invitation.
Yeah, just to say thank you, Peter. It's been really interesting, and thank you for spending time with us.
No, thank you so much.
And with that, we'll reach the end of today's podcast. If you would like a certificate for listening or just want more information about our guest and the conversation today, please take a look in the podcast description. I've been your host, Ceylan Simsek. Thank you for listening.